I think it's quite misunderstood. I think in the UK, Australia, other countries throughout the world, but it takes a lot more HCG, wouldn't it, to get a similar amount of elevated testosterone levels as would.
When you start testosterone, you're already low. Meanwhile, when you're using testosterone, you suppress this amount that was not sufficient. So you cannot resurrect from the death. It's like comparing a knife with a gun. I mean, testosterone is the real deal. It cannot be substituted by anything.
One type of person that couldn't use HCG would be those who have testicular damage. Still get scar tissue with subcutaneous insulin, but you can get subcutaneous scar tissue if you're injecting also even with water-based HCG, growth hormone, peptides.
I have to admit that with HCG that I'm using on a daily basis and G8s, I have some lumps.
So there you are. Have you ever wondered what the top esters are? What's the best ester to use for testosterone replacement therapy? There are many different esters available, everything from testosterone cypionate, testosterone enanthate, testosterone decanoate, and a blend of esters that make up Sustanon, which is a combination of testosterone propionate, some medium-acting esters, and longer-lasting esters. What are the best esters? Is there a best ester to use when you're on TRT? So hi, George.
We have the fast-acting esters, which is the propionate, but actually there's also the water-based that's rarely used. The suspension has no ester and actually has 24 hours half-life.
For the water-based, but that's not really commonly available at pharmacies, and no one uses it for TRT.
So by resembles a cream, so it comes off the system on a daily basis. So we have the injectable, we have...
Well, before we go into those, let's talk about the testosterone propionate.
Propionate, yes, so every 48 hours or 3 times a week.
Okay.
Then we have...
Which dose of the testosterone propionate? So there's different doses you can use. So in Europe and in the UK, we have available testosterone propionate that comes in 25 milligrams per 1 ml in a single-use ampule.
I would say if you use 25 milligrams, you're going to use it every other day. So 100 per week, let's say, every other day.
Between 75 and 100 per week every other day.
Exactly. Then we have the enanthate, which is actually, the propionate releases 80% of the ester, the enanthate 70%, 71%, and the cypionate 68%. So the half-life of the propionates is around 2 to 3 days.
One of the things, just before going to the enanthate, about the testosterone propionate that we found very interesting is in some patients who have used testosterone propionate at 25 milligrams every other day, they're seeing really normalized hematocrit and hemoglobin.
Yeah, that's what I say now. The half-life of the ester has to do with the microdose. So the only appropriate for microdosing actually is the cream and the propionate. Okay, you cannot microdose enanthate or cypionate properly because they have 5 and 7 days respectively half-life. So before you clean the system, you inject in another one, so they accumulate. So all the propionate is ideal for microdosing, strictly speaking, because as clear the system, then they inject the next dose.
Okay, so there is a study that talks about, and this is getting back to why some people would use a propionate, the elevation of hematocrit and hemoglobin seems to be less.
Yes, because it spikes less.
Because you're getting the
smallest dose
lower
available.
trough level as well. So the trough level of free testosterone seems to be a predictor of elevations of hematocrit and hemoglobin.
So that's why it's more important to have a lesser spike in the free testosterone rather than the total testosterone, because the free testosterone is the one that works, the real deal. And if it spikes, it's over the range, then more likely you're going to have...
On trough, if it's over the range on trough.
Yeah, the trough levels, if they spike, if they are over the range, then most likely you're going to have excessive estrogen and DHT boost that will lead to erythrocytosis, hemoglobin synthesis.
Okay. So have you seen testosterone propionate used in other ways? Have you seen 25 milligrams daily?
Now, in bottles, it comes at 100.
It does come in 100 in 2 ml.
So let's say 0.1, it is 10 milligrams. All right, if you do it microdose with an insulin syringe.
You don't
but usually it's in Italy comes 2 ml at 100.
100 milligrams in 2 mLs, and it also comes 25 milligrams per 1 ml. And at the Hormone pharmacy, we supply 25 milligrams in 1 ml because it's exactly.
If I had access to the Hormone, I would use propionate on a daily basis.
Yeah, would you? Okay, so there are some benefits, and I considered it as well. I just don't want to inject as frequently. So the next ester would be testosterone, let's say, cypionate.
Cypionate it's widely used in the US. It's a bit slower than the enanthate, and it's perfectly to be used once a week.
Okay.
That's the perfect
What
range.
dose once a week?
I would say 200. Well, you're gonna spike with 200 in one dose.
We can also go with 100 once per week. You can
Connor does.
100 every
Thomas
5
Connor
days.
does 100 every 5 days.
Yeah.
I would say you can do, let's say, every Monday now, 100, 150 or 200.
Okay. So what there are, I guess it depends on the right ester for the right person, right? Some patients don't want to inject that frequently. Other patients prefer having it set on one exact day per week, and they know that day. Other people are better using the calendar, and they set the calendar to do every 4 days, every 5 days, every 6 days, every 7 days. I think it just depends. So have you seen a difference between testosterone cypionate and the next ester, which is testosterone enanthate?
No, they're very similar.
Yeah, they're usually interchangeable, aren't they?
Enanthate is a little bit faster.
Absorb more quickly. So would you think it gives you a bit more of a spike or a peak? Or it's quite same?
Pretty similar, but in Greece we have enanthate. All I'm using is enanthate.
Okay.
Pharma grade. Yeah. And then we have the andecarnate, which is very slow, 60%.
So undecanoate is known as
the Nebido.
Nebido.
Yeah. It's around to be used every 2 or 2.5 months, 8 weeks, 10 weeks.
Yeah.
You know, the longest
12 weeks,
is 12 months or 3 months, 12 weeks or 3 months.
So with undecanoate, we're talking it's a whole 1,000 milligrams in one go.
Yeah, this is a major
4 mils.
disadvantage for spiking the hematocrit, but also the estrogen. So you get super high the first month, it kicks around second, third week. Right before the injecting again the 12th level at the 12th week, it's around 300. So you don't have a steady
So this is the argument.
spikes and then it troughs, and you don't feel well before the next injection. So you should bring it sooner, all right, around from 12th week to 8th week.
And this does happen sometimes in clinic. I mean, what amazes me about the undecanoate, Nebido or Avid in the US, is that it's not that new of a molecule. I mean, it came out undecanoate, as was the Andriol.
Yeah, but surprisingly, Andriol has a very fast
Half-life.
half-life.
It's supposed to work through the lymph, so you would take that, and that was supposed to slow it down. And so suddenly, by the manufacturer adding 4 milliliters or 1,000 milligrams in 4 milliliters, somehow people think this is just going to be amazing. It's going to increase the duration. But if you give, and yes, it has a low startup, right, low ramping up period, and it lasts a lot longer. But I suppose if they used to do 200 milligrams of cypionate every 2 weeks.
Yes, so 125 per week, which is a good dose in order to be below 1,000 nanograms per week. Okay, that's what I'm using every 7 days actually, half cc.
Of
Enanthate. So yes, if you take 1 gram in 2 months, you're gonna have 125 per week.
Okay, so I mean that can work for some. I think it just depends on what they're prescribed. Sustanon. Let's talk about Sustanon.
Sustanon is a blend.
It's a blend in the different esters.
It has a very fast acting propionate, but also a slow acid, the andecarnate. So it enters the system, but it clears the system slowly.
And then I think the longest one is the testosterone decanoate. It doesn't have undecanoate. It's testosterone propionate, phenylpropionate,
Isocaprate.
Isocaprate, and then undecanoate.
Yeah.
So that's.
So you feel the difference fast with injecting. It gets into the bloodstream.
But it's the testosterone propionate of the Sustanon mix is the lowest level. I think it's quite misunderstood. I think in the UK, Australia, other countries throughout the world, the Netherlands, other parts of Europe, there's Sustanon, but there's also Omnidrin, which is
Omnidrin in Poland, yes.
But it's exactly the same formulation now as the Sustanon.
I think there are 3 blends in Omnidrin.
4. It's the same. It's the same exact combination as Sustanon now. That's a good question. So how long does HCG take to increase intratesticular testosterone?
While on TRT?
Let's say, as a monotherapy. So they just did HCG alone. Now, the experience why HCG isn't used alone. Let me go.
Monotherapy, but it shuts off the LH.
Yeah, it shuts off your LH, so there's really no advantage when you compare it to testosterone other than you keep your testes going, but it takes a lot more HCG, wouldn't it, to get a similar amount of elevated testosterone levels as would an injectable testosterone. So you can do 100 milligrams every 5 days with testosterone cypionate. It may take, I don't know, 500 IU of HCG about every other day, maybe to get it close to the levels that you would reach with the injectable testosterone. What do you think?
Well, when we use HCG as a part of the PCT protocols in bodybuilders, we use it every 3 days, that's the half-life. And I'm telling them to use 5,000 to 6,000 IUs. And then after 2 weeks, they feel a great kick in libido, in mood, even in strength. So after the second week, they feel the difference.
5,000 to 6,000 IUs.
Totally, totally.
Divided
So dividing 5 doses
PCT.
or 6 doses of 1,000.
Okay.
So we do kind of a small dose, microdosing, every 3 days.
About 500 IUs.
2,000.
2,000 IUs.
Every 3 days.
Every 3 days.
Yes. And during the second week, they feel the difference.
Okay, so it does bring up but it's a lot of HCG to use.
I wouldn't compare apples with oranges.
Yeah.
I mean, it's like comparing a knife with a gun. I mean, testosterone is the real deal. It cannot be substituted by anything. Mm-hmm. Now, bring them together, if they join HCG, it's much better also because you don't shut off your own production, your balls are still alive, and also it's a libido enhancer during TRT because this intrareticular testosterone will give you more sex drive.
Well, not to mention that if you have the cost involved, having testosterone and HCG can sometimes be more, but if it's actually, because you're using a smaller dose of HCG, it's not as cost prohibitive as if you had to use a massive dose of HCG.
I'm doing actually 100 IUs every day. I break it down as Chrysler used to say, John Chrysler, that mimic your own production of testosterone with small doses of HCG.
One type of person that couldn't use HCG would be those who have testicular damage. Right? If you're primary hypogonadism,
or perhaps seminoma, testicular cancer survivors.
Yeah, because then there's not a whole lot to produce.
But you believe that in testicular failure in primary hypogonadism, HCG has no benefit?
I think that's very little. If your testes aren't going to take a signal from your LH, which is better, and FSH, why would it do any better with HCG? Enanthate is more estrogenic than cypionate.
No, actually, it remains in the system 4 days, 5 days, while cypionate 8 days. Therefore, there are more chances of cypionate to aromatize. The opposite. The sooner it clears the system, like propionate, for instance, it doesn't aromatize.
They're nearly identical.
It's 71 to 68, but if you search out the half-lives, it's 5 days to 8 days. And also aromatization is up to the dose, okay? Also,
exactly. How much dose?
Adipose tissue, ethanol, soy, okay?
Well, probably your first step is try to get, the one thing I've heard from some doctors is just increase the total dose, but there are still some men who may not convert, and we've seen this. It's rare, but we've seen it a few times.
I would add HCG.
You would add more HCG. And then if that didn't work, a synthetic estrogen. Yeah. Or bioidentical estrogen probably is a cream. And they do make estradiol injections as well, but maybe a little bit of cream to help with that.
It's counterproductive.
Well,
it works in the paper, but it raises LH. So total testosterone, SHBG, and free testosterone goes down. So it's counterproductive, especially in large doses. Crystal said 12.5. In very low, it may work. But if you increase the dose, you feel lousy. You have retinopathy, blurred vision. And also, it's...
Well, the issue with some, like Clomid, is it agonizes the estrogen receptor. So it's going to be affecting the liver. You're going to, raise SHBG. You have some pro-estrogenic effects, and then you're going to have some anti-estrogenic effects in the brain. So, Clomid is a tricky one because not everyone feels.
And also, they trigger clotting, the SERMs, huh?
Yeah, and potential clotting with SERMs. Yeah, one of Dr. Mark Gordon's programs for TBI, he is a big proponent of Clomid. Remember Dr. Mark Gordon? For those who had traumatic brain injury, he was using a clomiphene to help stimulate the brain, plus adding a bit of testosterone into the mix, no more than about 60 milligrams.
I would say HCG is superior to Clomid, to the side effects, And to the efficiency in the testicles.
Well, I think people subjectively feel better with the HCG or exogenous testosterone than they do with Clomid. Estrogen, high estrogen, increase the chance of infertility in men.
Now, usually the high estrogen shut off GnRH for LH.
Yeah, it's part of the feedback loop.
Yes, yes. And in such case, you have less testosterone that matures the sperm. In natty people, okay? Now, in natty people, this way. Now, in people within replacement therapy, estrogen is beneficial, okay? We shouldn't block it.
Of course. So you're doing TRT, HCG, and will the increased HCG, which causes increase?
I guess not, because HCG increases estrogen through the intratesticular testosterone, and HCG improves fertility. I wouldn't say a negative factor of estrogens during the fertility, because this is what HCG does.
Well,
Indirectly,
testosterone increases, estrogen increases.
Yes. It depends on the lifestyle somebody wants to use. Okay, if he wants to do, if you want the perfect microdosing, I would say is the cream.
For doing
the lesser spike. Okay. If somebody travels a lot and is not convenient with injections, okay, do it with anticonate every 8 weeks, I would say.
But for the general population, I mean, we've seen in some of the...
If I had propionate in my country, I would use propionate to avoid the spike and elevate my SHBG.
SHBG.
My SHBG, yes.
I think we see, at least in the UK, quite a large number of patients using Sustanon in varying degrees every 5 days, similar to the Cypionate. And I found personally, when I switched from Cypionate years ago, when I was in the States, to Sustanon, it was nearly a 1-for-1. But I've done as well as...
Have you tried the Greek Enanthate?
I've tried the Greek Enanthate. I've tried the different Cypionates. Yeah, they're very comparable. When I didn't have my Sustanon and the Greek Enanthate was there when I was in Greece, I didn't miss a beat. I used the same exact dosage I was doing with Sustanon, with Enanthate. I didn't notice any difference with either of those.
It comes in 200 or 250?
It comes 250, one of the brands, in an ampule, 250 in 2 mLs of olive oil and ethyl oleate. So it's a combination of mostly olive oil and ethyl oleate. And that's made in it. Well, it's licensed in Spain by an Italian company. It's also made in 100 milligrams in 2 mLs. But there's a 250, 100 milligrams in 2 mLs. From the United States, there's 2,000 milligrams in 10 mLs, and there's 1,000 milligrams in 10 mLs. So these are the different options that are available mostly throughout the world. I know there's a few other ones. So what is the optimal one? Similar to dosing, what's going to be best for the individual patient? And I think it's a way up of cost, convenience, what's available in your country. And I think that, for me, I've got a choice between all of them, and Sustanon seems to be one of my favorites with that one. But again, it just depends on what works for most people, and what we've seen is that seems to be working the best, but there are many other options that we have, especially at our pharmacy. Okay. On paper, and for some people, subcutaneous seems to work well. The question is where and what do they consider subcutaneous? So, the Chrysler, he kind of popularized Dr. John Chrysler. He has this video of him looking quite buff and tanned, and he goes into the fat pad in the stomach. Now, when I was younger, and some of our patients have also tried it, and I've got pictures of people in our Facebook group that sent me the result of them doing the subcutaneous injection. What we've seen are these lumps and bumps and bruises, and the bruises, they last for weeks.
You have to know that the blood supply into the subcutaneous area is much poor.
And that's the other reason.
It's slowly absorbed the day after, I guess. And also, if you inject, of course, oil into the fat, you create the lumps, especially if you are lean.
So, right, that's not a very nice
Unlike the intramuscular, the shallow intramuscular, as Virgil says, into the delts with an estrogen series that goes straight to the bloodstream and is absorbed abruptly.
Well, essentially, yeah, and that's what I love about Dr. George's compromise is that it is a compromise. So for some guys, they're fearful.
It was for the sake of the scar tissue initially by Chrysler.
Yeah, but here's what we've heard from some of the other doctors on our channel is that you still get scar tissue with subcutaneous insulin. If you're injecting over
to a mind, it doesn't hurt that much.
But you can get subcutaneous scar tissue if you're injecting. So even with water-based HCG, growth hormone, peptides.
I have to admit that with HCG that I'm using on a daily basis and G8, I have some lumps.
So there you are. So this thought about
and you can see this in bodybuilders
scar tissue.
when they do the abdominal pose, because they inject insulin into the stomach and GH, they have these lumps because they are very thin, the skin.
And they're creating maybe scar tissue. So where the muscle, if you inject into the muscle, it's got more blood vessels, so less chance of it forming scar tissue.
More recuperation, eh?
Yeah, more chance to recuperate, more chance to heal. So that was from Dr. Kathy Smith O'Neill, who's been on the channel. She acknowledged that. So where I love your compromise is this. For those who are afraid of the extra long needle on top of the syringe and all that goes along with it, some people are fearful of that needle, but they're not as fearful of the small subcutaneous injection, or the insulin syringe, which is an all-in-one needle and syringe together.
27 gauge, I think.
Oh, 27. I think 27 gauge is quite good because it's large enough to accommodate the oil. So if you do it in a thin in an area like the quads or the delts, then you're going to essentially do an
intramuscular. You penetrate all the muscle.
Yeah, you're going to do an intramuscular injection, but you're not going to have all the lumps and bumps that you normally get from that subcutaneous injection, especially when guys want to put it right in the abdominal fat. And again, like you said, the other benefit of going intramuscular is, one, it says it right on the label. If you ever see Cypionate, testosterone cypionate, it'll say for intramuscular use only. Right? So why would you put it subcutaneous? If you're afraid of needles, most of the pain is in the is in the initial layers of the skin. Once you get through the skin and into the muscle, most of the hard work's been done already. Most of the pain is, you've already been through it. So once you can get yourself convinced to go into the muscle, it's not that bad. Now, the degree and how deep you go will depend on whether you use an all-in-one insulin syringe or you use a 23, 25 gauge needle to do the injection. And there are some techniques where you change out the needle and do a smaller needle. So you would maybe withdraw with, if it's an Ampion 18 gauge needle with a filter on it, and then you would swap it out to a 25 gauge needle for the actual injection. So now it's very sharp, or even a 23 gauge needle where if it accommodates that really, really viscous oil and you don't have to push as hard. So you have less pressure there.
The serums elevate, they kick the brain, that's why they elevate the LH and FSH. Yep. And afterwards, LH and FSH kick the testicles for the Sertoli and the Leydig. So indirectly they kick the brain, and afterwards they kick the testicles. That's what serums do.
But when you discontinue it, it will normalize it.
Yeah, I guess so.
In time, I mean, if you're once that, because essentially the serums
I've seen
are
in the
blocking
paper
the brain. Yeah.
Men that doing the PCT protocol, and right after, the week after, it's still elevated. I've seen LH of 10, for instance.
Right. Oh yeah, I've seen quite high LH and 10, FSH 15, as well.
Yes.
And we've seen some success stories with patients who, have used.
Could be temporary. They rise and fall again.
Yeah, and I've seen that before with some patients that had used they try to
feel
recover.
Good, but temporary. After a while, they go down again.
Yeah, it's usually because of the racemic mixture of clomid, right? So you got the two different zoochlomiphene and N-clomiphene, and the N-clomiphene is more anti-estrogenic and the zoochlomiphene is more pro-estrogenic, but the zoochlomiphene lasts longer in the body than the N-clomiphene.
Tricks the hypophysis by lowering the estrogens, and then they kick the hypothalamus for generates the indirect stimulus.
It would be ideal if there was another substance that did the exact same thing but didn't have all the negative effects. Something that, who knows, through future drug discovery would do the job. I know there's some talk of kisspeptin as a peptide.
But I had a patient, 25-year-old, overweight, I would say obese, 260 pounds, 6'2", 30% body fat. His total testosterone was 300. He tried kisspeptin, no success story, and then he went to TRT.
Okay, so it depends. Kisspeptin's not available as a pharmaceutical. It depends where the kisspeptin came from. Was it from a reputable source? These are all experimental. They've done studies on kisspeptin, but it's a precursor hormone to launching your GnRH. So some think it helps kickstart puberty, potentially kisspeptin, and maybe kisspeptin has been studied as a possible.
And also the triptorelin, you remember? tryptorelin.
Yeah, but tryptorelin,
cancer,
yeah,
basically to castrate because it's GnRH agonist.
But the dose that they use burns out that
exactly.
that axis, which
you
is
have
why
to be very delicate with the dose.
Tiny dose. So, but with the kisspeptin, they've also studied it. There's been some recent studies looking at kisspeptin for improving libido. Again, these are research chemicals only, and there's going to be more data for it to come out. And it needs to be an approved drug, because if it's not an approved drug, you're really risking your health and side effects, because you don't know what other negative effects it's going to have.
I would say the best option is HCG when we kick the HPTA, but also when you implement into and you join testosterone.
Well, my personal experience with HCG has been I'd use HCG 500 IU 3 times a week, and I had not used HCG for a long time, probably years before that. I did a semen analysis. I've said this before. I had 156 million sperm, 72% motility after TRT and HCG together. Of course, we've also seen patients who had bad fertility before they started. They did TRT with HCG, and they can barely get theirs up towards 5 to 10 million sperm. So it really depends. If you come into it and you have infertility to begin with, you can't always expect miracles. But if there's no damage to your testes, then there's no reason why you wouldn't get a good result.
You see, I had a varicella. I was 50 years old. I managed to become a dad. Even 8 years on testosterone and HCG, of course.
Oh yeah, you're a perfect example.
But even though I had a varicocele,
Varicocele.
Varicocele, yes.
So there you go. And I have a varicocele as well. So
really?
Yeah.
Even though you had 156 million?
Yeah, well,
I never had more than that.
So
you should become a silent door,
Yeah, I'm curious what they are now, but I've not used HCG now in quite a while. So
5 years ago, an ex-bodybuilder, 50 years old, came to me with 200 nanograms, okay? He was hypogonadic officially. He got it prescribed by endocrinologist, Nebido. He started my protocols with Enanthate, okay? Now, meanwhile, he wanted to start competing in cycling, another sport, with testosterone. He was doing superb. But he joined a club, and they told him, no, you cannot go this way. You should come off natty, and he preferred to ruin his health for the sake of the games. Now, 6 months after, it's still zero, his testosterone, and he feels crappy, like an old man. So you cannot restart, and especially when you start testosterone, you're already low. Meanwhile, when you're using testosterone, you suppress this amount that was not sufficient. So you cannot resurrect from the death. It's not something healthy. The only reason you should stop it for a while could be for the sake of erythrocytosis. I tried this during the COVID, okay, but I was feeling lousy.
How long did you stop?
1 month only.
Okay.
To drop my hematocrit. I was feeling lousy. My A1C elevated, libido, mood, everything went down, fatigue. Okay, it's like asking, can I stop my T4? No, you cannot, because you don't produce anymore.
No, exactly.
It's not a trendy thing, the TRT. It's a treatment to a disease that has no cure. People should understand this. We don't just start TRT for the fun of it.
No,
this is not a cycle. It's a replacement, meaning that you supplement something that is insufficient.
No, I agree. And I think there is some sexiness about it in the public, partly due to stigma, partly due to just people think the testosterone could be the cure to all their problems. And many times, if you have a deficiency in testosterone, yes, it will fix many of those problems. But it's multifactorial. There's many other factors that
it has many health benefits. We discussed this in Orlando. Doesn't mean that somebody who has a heart failure and take testosterone will improve. And we shouldn't misjudge and mislead that it's the solution to all your health problems.
No, it's not. But then having low testosterone won't
It doesn't
help
mean if you die with heart failure, taking testosterone, we blame testosterone for this, okay?
Do you have any advice for people that get tingling in the hands, numbness in the hands?
If you have numbness, could be carpal tunnel syndrome, okay?
What about if the muscle gets quite big and puts pressure on the nerve as the muscle grows? Sometimes you can have some tingling. Certain mattresses I found will cause my hands to go a little bit numb. I get that sometimes in my hands, just the hands fall asleep.
You think it's vascular or it's neurological?
I don't know. It could be both. Some people will claim some numbness in the hands if they're using too much. Was it B6? Vitamin B6, yeah, because some people use B6, that may cause a little bit of what feels like a neuropathy or some tingling. Book in an appointment with one of the docs, and we can have them talk to you about it. If you take the HCG, you're going to shut down your pituitary axis. The only saving grace is your testes are still going to be alive. So I think one of the issues is when someone is going on testosterone replacement therapy, or they're doing other forms of testosterone, they end up shutting down not just the brain, but also the testes. And then when they stop everything, you're hoping those will all come back on, first the brain, then the testes. But by that time, the testes may have atrophied and they're not working like they should do. If you use HCG only, the saving grace is, okay, you shut down the brain, the testes are still primed. It's like it's like a factory. If a factory is producing all these widgets, and then the head office shuts down and the factory shuts down, well, then it's going to be really hard to turn everything back on again. But if the factory is still running at a much lower level of production, and just getting the order back on might help. That's a terrible analogy, but it might help improve the testosterone levels on its own. But again, HCG is one of those things that, as an adjunct, if you're using it monotherapy, I don't think it's going to give you the optimal levels that you're expecting, and there still will be a price to pay at the end, right, waiting for your levels to return to normal. The only, like I said, saving grace is your testes will have been exercised, if you will, during that time. But again, you can still upset the whole balance of things.
Absolutely.
Yeah,
yes.
Dr. George. Yes, you can. We see many patients. Yeah.
Some people add also HMG, which is even more beneficial, and you can HMG, you can
or recombinant FSH.
Synthetic FSH. Yeah, you can reverse oligospermia. I've tried it many times.
All right.
The problem with Cypionate and Enanthate is that if you don't wait until they clear off, then you accumulate the next dose on top of it.
A bit, yeah, and you're going to have.
That's why the perfect microdosing happens with Propionate.
Well, look, we've seen some patients that have come to us from elsewhere that were doing 10 milligrams a day of testosterone cypionate, okay? And they had really elevated hematocrit and hemoglobin, and levels were higher than they thought they would be, because they're only doing 10 milligrams subcutaneous, which also points to the picture of you can't predict the release of that testosterone as easily as you can with intramuscular, because it's more vascular in the muscle compared to the subcutaneous and fat area. So because of this, when they were switched to testosterone propionate, 25 milligrams every other day, yeah, the hematocrit and hemoglobin normalized. It didn't go to the levels that once were on the cypionate, because they had time for it to go up and to clear out.
And we know that cream elevates to a lesser degree the hematocrit.
To a lesser degree, but in some patients it could still increase it, yeah. It can still increase it. So,
well,
yeah,
it has a logic to that because it's a microdose.
Yeah, book an appointment with one of the doctors at BMH, and they'll be able to make the adjustments if they haven't already. If you like content like this, do click like and subscribe and hit the notification bell if you want to get our latest updates for when we drop content. It really does mean a lot. And until next time, to your wellness, this is Mike.